Thank you. This is an important question because patients with non-ST elevation ACS are increasing relative to STEMI. So this involves many patients, and risk stratification is key to optimize the timing of revascularization. I think high risk is very easily recognized. If the patient has ongoing ischemia, ongoing chest pain, and maybe hemodynamically unstable, then this patient should be treated as in STEMI, go immediately to the cath lab. In cases of high risk, this is a little bit different. There, the recommendation has changed to 2A. So you should consider, but you should really carefully risk stratify. So if the patient has, for example, high troponin levels, a very clear ECG confirming the diagnosis, and if you have ongoing dynamic ECG changes, ST changes, then this patient should be treated invasively within 24 hours. So this high-risk category is the one that is maybe the most, let's say, debated, because it depends really on multiple factors, including the individual risk of the patient, comorbidities, for example. If the patient is old, has kidney dysfunction, has maybe other diseases, you may want to wait until the patient is stabilized by medication and until you have a more clear picture of the comorbidity. Then you can decide whether to do the invasive strategy within 24 hours or even wait longer.
Okay.
And the non-high risk or the low risk patient are those patients where you don't know. You don't know whether it's a real diagnosis of non-STEMI. And there you may even involve non-invasive tests like a CT angiogram, or an echo, a stress echo, even if the patient is stable. Anyway, other tests to really confirm that the patient has a coronary symptom and a coronary syndrome and not something else. So differential diagnosis in this low risk category is very important. Well, we are discussing how to organize clinical trials in the future with the help of AI, for example, or registry-based randomized trials, things like that, where you can use data from electronic health records, for example. So that's the future.
Yeah.
But I think scientific questions relevant to acute coronary syndromes include, as you just said, a better risk stratification, whether to use GRACE score or other clinical scores, risk scores, to better stratify the patients. That's a question that is wide open, and this has been suggested by some groups, that we as ESC should look into this question of non-ST elevation ACS and how to better risk stratify and find the optimal time point of invasive strategy. And I think other research questions relate to adjunctive therapy, like anti-inflammatory drugs, which are on the horizon, RNA-based therapies, and of course, we wait for the studies to show that targeting lipoprotein little a, for example, is something that we should target in ACS patients. So I think there are many questions that we can address, but there is only a limited, let's say, capacity and resource to really perform these studies. It's a challenge because we are a multinational society, and there's only so much that you can do, but we try hard to promote research in that direction. I think the field is most advanced in ECG diagnostics. So in the situation where a patient has unclear symptoms, and the ECG is also for the human eye non-diagnostic, then I think AI algorithms can help to more precisely predict whether this patient has slight changes in the ECG that may predict a future event. So that's a field that is very interesting because their AI is already quite advanced in ECG diagnosis. Other biomarkers are also interesting. And I think another area is, of course, echocardiography. So, for example, if you go to non-invasive assessment by stress echo or so, studies have shown that AI has a role in being more precise than humans in predicting wall motion abnormalities and other signs of ischemia in the heart muscle. So I think these two areas are interesting. Other areas we will see. The field is advancing fast, but we have to keep our human control of the validation of these algorithms. Very important. Very good question. And I see huge advances made in China in this period, since my last visit. When we talked about interventional approaches, I was here with an interventional cardiology group. I think an open mind is always the most important thing to foster collaboration. So mutual collaboration depends on open exchange of ideas, new data, and how to implement them in a huge country like China. I think the real opportunity for collaboration lies in the huge population in China, the many more patients that you can recruit in a given time for a study with your advanced technologies that you are able to use in China. So I think there you have a great opportunity that the rest of the world can really benefit from, because you have the technology and you have the populations. And I think based on this, we can not only expect randomized trials coming from China, but also how to select the right patient populations for randomized trials in other countries. So I think here we really should follow up on that to intensify the collaboration and exchange. And we want to promote this, and we would like to enhance this exchange of experience and learning together.